Ma'am, we are live now. We are good to go.
Great.
Yes, you can start now.
Yes, ma'am. So once again, very good evening, all the faculties and delegates present over here. On behalf of Kurna Remedies Private Limited, I, Vasist Mehta, welcome you all for the Core Connect live webinar on management of nausea and vomiting during the pregnancy. So we shall start our session by Ganesh Vandana, followed by lamp lightning.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
Now, I would like to invite Dr. Charulata Bapai ma'am. Ma'am is a national coordinator at Breast Committee Foxy. She is director at GEMS Hospital and Endoscopy Center and Ashwin Hospital, Pune. She is also an honorary consultant at. Thank you so much, ma'am.
Thank you so much, Mr. Vashisht. Thank you very
Over
much.
to you, ma'am.
Thank you so much. A very good evening to each and every one of you here. It is indeed a pleasure to conduct this program, which is on a very apparently simple and basic topic, nausea and vomiting of pregnancy. Is it real? Is it a myth? Is it just a psychological factor and fear? And it is exactly what we are here, got gathered together today to find out what is the etiology, what is the pathogenesis of this particular problem, and how do we need to help our patients regarding this. Such a simple problem, such a common problem, but let us get to the root of it through this fantastic panel discussion that has been organized here today through Core Remedies. And whom do we have here today as our expert moderators and our chief moderator? Can we have the slide, please? We have with us none other than Professor Dr. Sampath Kumari Madam as our expert in this field. Indeed, she is an expert in so many fields, and I'm sure that she's going to guide us fantastically today also. She's Chief and HOD of Muthukumaran Medical College and Research Institute from Chennai. She's the Foxy Vice President-elect 2022, Founder Secretary TNFOG, such a big organization today. She has a number of other accolades also to her credit. She has received a number of awards, including the Shailaja Pandit Women's Empowerment Award, the Foxy Dr. Durusha Distinguished Community Service Award, and the Karmaveer Chakra, which is the it's a national award for adolescent activities. Madam has been the chairperson of the Foxy Adolescent Health Committee, and she's guiding all newcomers like me fantastically. Welcome, madam. Welcome to this particular webinar, and we are looking forward to your inputs for the same.
Thank you, Dr. Charulata.
Thank you so much, madam, for being here.
Yes, I think have we lost Dr. Charu's connection? Yeah, Vasist, you can go ahead. Just show me next slide. Yeah. So I think by the time I continue with this, and it's a proud privilege for me having you both, Madam Sampath Kumari and Madam Manju Verma, as expert for this panel discussion. As Dr. Charu has rightly said, it is though very simple and basic, much needed in day-to-day practice, and of course, it has got a diverse subjects to be discussed. right from etiology and pathology, and of course, various modalities of management. So I take this opportunity to welcome Dr. Manju Verma, who is the retired professor and head, and she is the past president of UP chapter of obstetrics and gynecology. Madam has got a certificate of honor in medicine, and she's got BC Pant gold medal, Lakshmi Ratan Pandey silver medal, and Madam has got so many accolades to her credit. Lots of scientific papers and publications in national and international journals. And on top of that, from my side, what I know Madam as a wonderful, loving person. And Madam, I'm very happy to have you with us as expert. Looking forward to your inputs, Madam.
Thank you, Dr. Sneha, for taking over. I think I
It's
just
my
lost
pleasure.
connection
My
for some
pleasure,
time.
Sneha. It's my pleasure.
Thank you, Madam.
Welcome, Dr. Manju Verma, madam. Welcome to this wonderful webinar. We're looking
Thank you,
forward to
madam.
your inputs. And now, our chief moderator for today's panel discussion is none other than my friend, philosopher and guide, Dr. Sneha Bhuyar, ma'am. I think all of us here have really experienced her vibes as an academician, as a friend, and we've all seen her extracurricular activities also. Madam is currently the chairperson of the Study on Female Breast Committee for FOPSI. She has received numerous awards and accolades. She has a national by FOPSI, the Anandibai Joshi Award by the government of Maharashtra. Madam, a reasonably small, and in spite of being in that place, so much good work for society in general, and of course for FOPSI also.
Thank you, Charu.
Madam
Thank you.
Numerous best wishes for all your future endeavors, Dr. Sneha Bhuyar, madam. And over to you for the panel discussion.
Yes. Thank you so much, Charu. Can we have the panelist CV wishes? Yeah. So I'm very happy to welcome our dear panelists and of course my committee member, and not only member but East Zone coordinator, who is a very vibrant person, very sound academically, Dr. Indrani Roy, who is a senior consultant and head of department of gynae in the Nazareth Hospital, Shillong. Welcome, Dr. Indrani.
Thank you, ma'am. Thank you so much.
And we have Dr. Charulata Bape, whom you just heard. She's our national coordinator, press committee FOPSI, and she's a vibrant personality from Pune. We have Dr. Rashmi Kahan, who is a very dear friend from Amravati. She's also the member of press committee, of course, member of various committees of FOPSI, one of which is press committee. And we have Dr. Deepa Mukundan, who is the present secretary of Trichy Obsgynae Society, a multi-talented, multitasking personality from, and of course, who is an executive member, committee member from TNFOG, and she's got various awards and accolades to her credit. Her areas of interest mainly infertility, endoscopic surgery, and high-risk obstetrics. So welcome, Dr. Deepa Mukunda and Dr. Meeta Gupta, who is from Jammu, our dear friend. We have been on various platforms together discussing on variety of subjects. So Dr. Meeta Gupta is an associate professor, Department of Obsgynae at Acharya Shri Chandra Hospital and Medical College, Jammu and Kashmir. And welcome, Dr. Meeta, to this very important but very basic subjects. So with this brief introduction, I would just like to share my screen and start with the panel discussion much. I know our time is very valuable and we have to make use of this very precious time. Time is money. So without much ado, we directly go to the subject, and I would like to ask my dear panelists. I have very senior experienced and knowledgeable experts whose inputs I'm going to ask specially. So just to start with this, this is a routine scenario in your OPD. You see a happy couple, knowing that she's pregnant, very happy, and she is facing so much of problem. She feels like eating so many things, drinking so many things, but she's just not able to, have anything, and she's come to you for help. So what are you supposed to advise her? What is good for her? What is nutritious for her? At the same time, what is going to relieve her vomiting? What's going to help her improve her intake and the growth of fetus as well? So that is how we have to, we have to just counsel the couple that yes, pregnancy is a good news, but with this, versus, can we mute the rest of the people? Yeah. So how to stop this vomiting and how you can help her. So with this, I think we go ahead. I would just like to start with Dr. Indrani. Panelists, please put on your mic and video as well, if possible. Indrani, what do you feel? What is the incidence of hyperemesis, rather nausea and vomiting? We will go to the hyperemesis later on. What is the incidence of nausea and vomiting in your practice, or maybe day to day, what you face?
Yes, thank you so much, ma'am, for this opportunity today. And going to the topic, I think nausea and vomiting, around, I think 80% women will experience some form of the other. It might not be hyperemesis, but to some extent, I think in my practice, I get almost 80% of women who suffer from nausea and vomiting during pregnancy. It might be just simple nausea, or it might go extend up to hyperemesis, which might need hospital admission.
Yes, very true, very true. Dr. Rashmi, I would just ask you whether all these women who suffer nausea, they also face the problem of vomiting, or whether it's only nausea and not vomiting.
Madam, not all the women who suffer from nausea suffer from vomiting. Most of the patients, they suffer from nausea.
Is it that, every pregnancy she has to have nausea, vomiting?
Host is muting me.
Hello?
Hello, madam. Not all the patients who suffer from nausea will suffer from vomiting. Only a percentage of females will suffer from vomiting, especially if they are primary gravida patient.
Correct. So of the 70 to 80%, what Dr. Indrani has quoted very correctly, almost 50% of them have nausea as well as vomiting, but 25% have only nausea. And how much is the incidence of hyperemesis gravidum in your practice? Dr. Meeta, I would like to ask you.
Thank you, ma'am, for the opportunity. Ma'am, the incidence of hyperemesis is not as much as nausea, vomiting, because I think so it is not even 1% of our patients, but the prevalence is seen more in summer seasons, ma'am.
Correct.
I don't know, maybe just because they are a little less of water intake in summers and too much of dehydration. There are some patients who usually present to us with hyperemesis more in the summer season, but incidence is very less, probably less than 1% of the entire OPDs, ma'am.
Okay. Dr. Deepa, do you agree with this statement that the incidence of hyperemesis is more in summer, or is it because of the dehydration, its manifestation is more common?
I think Rashmi, we can move to the next session.
Good evening, ma'am. Am I audible?
Yes, yes.
I think I don't believe in seasonal variation. I think it's because more of because of dehydration, it is more evident, at least in summer. I think the nausea and vomiting is of unknown origin as of now. We have very little clues of exactly what is the reason, and there are peculiar associations for nausea and vomiting. Although the seasonal, I'm not for it.
Okay, correct. So, Dr. Charu, are you here? I think.
Hello.
Yes. Hi, Charu.
Hello.
I think we will have, Dr. Charu, just let us know, what do you feel? What is the origin of this nausea and vomiting? How does this happen?
Yes, so a number of mechanisms have been suggested for this. The exact mechanism of which is known for sure. It's related to metabolic and endocrine factors of placental origin in a large way. So, increased beta HCG's values is probably one of the important factors which is said to be playing a role in nausea and vomiting of pregnancy. So, there is a central action also and a peripheral action also. Yeah. So,
so you have a trigger of these vomiting centers, mainly the vomiting center and the chemoreceptor trigger zone. And of course, you have the theoretical aspect here just a little bit. The receptors, various receptors, muscarinic, dopaminergic, histaminic, and 5-HT3 and neurokinin receptors. But you have certain precipitants. Like toxic material or food particles in the GIT, visceral pathology associated, and vestibular disturbance as well. You may have CNS stimulation and toxins in the blood as well. So as you have rightly said, Charu, it is mainly the hormonal and metabolic. And maybe some kinds of other stimuli may contribute to the hyperemesis part of it. Though the normal nausea and vomiting of pregnancy, what we label as morning sickness, is mainly because of these hormones. So, Madam Sampath Kumari, we would like to have your opinion about this, initiation of nausea and vomiting of pregnancy.
Yes, thank you, Dr. Sneha, for the wonderful opportunity. As everyone told, this nausea and vomiting is physiological. When it goes pathological, it is hyperemesis. So 70 to 80% women will have, and it will subside from 4 to 9 and 7 to 9, as you have mentioned. Some patients, it may extend even up to 16 weeks. And less than 5% till the date of delivery, they are having. So mainly the counseling is very, very important. And of all this, the psychological effect is also important. So the counseling the patients that without vomiting, there is no pregnancy. As everyone told, nausea may be there, vomiting may not be there. Even for the nausea, we can start the management. Thank you, Dr. Sneha.
Thank you so much, Madam, for your inputs. And now we go to Dr. Charu. Charu, we have this first case, primigravida with 2 months amenorrhea, who comes to you with severe nausea, vomiting, and weakness. When you inquire about her number of vomitings, she says it's maybe 2 to 3 or 4 vomitings per day, and that too especially after having food. How do you grade this severity, whether you label it as mild, moderate, or severe, and how do you manage it?
Yes. So thank you for the question, Dr. Sneha. This young lady, 2 months amenorrhea and complaining of 3 to 4 vomitings daily. This goes into a reasonably severe form of nausea and vomiting that she's suffering from. The severity can be assessed by the number of vomitings per day, on investigation by the presence of ketonuria, and thirdly by the amount of weight loss that she is having. So these will pinpoint and help us come to a diagnosis about the severity of her problem. Now, when she comes into my OPD, first thing I would want to ask her would be, a little about the investigations that are done and a little about the diet that she's having. We see that,
with this number, Charu, with this number of vomitings, do you label this as severe hyperemesis?
See, she's throwing out everything. Okay. As per definition of hyperemesis, they claim that these 3 factors have to be present. Now, I don't know whether she's had weight loss. I don't know if she has ketonuria. Yes. So if she's having all this, then definitely it is severe. But if it is just the first time she's come, she's vitally stable, and she's talking about 3 to 4 vomits per day, then I will not label it as severe. I'll have to have the bigger picture to find out exactly how good or bad is her condition currently.
Yes. So, Dr. Deepa, would you like to comment on this?
I agree with Charu. We cannot, some women can report even mild nausea as being severe because the patient's history may not
Exactly.
be
You know,
as,
you have to
they may
differentiate
be
what
little
is subjective and
sensitive.
objective. Yes. Yes.
They may be a little sensitive, so they can say it is severe, and they can feel it bothersome. So we have to have objective signs of dehydration, objective signs of history-wise giddiness. Patient is unable to eat anything more than 3 times, passing very less urine, high colored urine. We have to go into detail about the history and whether she's having giddiness, palpitations, and she has to take to bed. Leg cramps is very common. So whether she needs to take to bed for taking rest. So with the history and a proper clinical evaluation, we have to arrive at signs of dehydration, in which case then we can brand her as a severe case.
Correct. So Dr. Indrani, how do you manage this case now?
This particular case, like the one you have just shown?
Yes.
Okay, so I think if she first comes to my OPD, I would like to check on her whether she's having any signs of dehydration or not. How much is her oral intake, whether she's being able to eat or what, or even if she's throwing up every time. If that requires, then maybe she might need a hospital admission if she's not being able to eat at all, that she's throwing up every time whatever she's eating. Plus, if she has signs of dehydration, then I think I would like to admit her and manage the dehydration also. I look for urinary ketones and of course the electrolytes also. But like in the first visit, if she's okay with eating, not any dehydration, only 3 to 4 episodes of vomiting, then maybe I would start her on oral medication.
As you have rightly pointed out that Dr. Indrani, I would like to interrupt you here. As you have rightly pointed out that she's, you know, a sensitive kind of person. She's just telling you that the moment she eats something, she vomits, but may not be that she throws out everything. And she's quite comfortable. Okay.
Okay.
So it's a mild hyperemesis, though it is a hyperemesis.
So
how would you like to go ahead with
in such a case, I think I would really take on her counseling. I would really like to advise her regarding how she's eating. You know, we have to say one thing to the patients, that it is not that you have to eat your regular food. People have the notion that if they are rice eaters, they have to eat the rice, and otherwise something is going wrong with my baby. So I have to impress upon the fact to her that you eat whatever you can tolerate and whatever you like. Even the sight of something, the smell of something might put her off. So I would like to add on that, please try to eat whatever you feel like eating, and try to have small meals frequently, because we have the concept of having 3 large meals.
Correct.
But in this case, we have to, like, you know, she can space out. She can say that we can tell her that you try to take small meals frequently, and then change your food according to what you can tolerate.
Yes. Any suppose maybe whatever little meals she's having, she's not tolerating. So whether you would like to add some liquids with electrolytes, whether you would like to give some oral rehydration. Yes.
Yeah, usually we can give, but most of the time the oral rehydration, the ORS, is also not well tolerated by such patients.
Exactly.
They have that feeling. So I think she can have some homemade liquids, like, you know, you have like with salt sugar solution, or some dash of lime and all, which she can tolerate. No, instead of the which is available in the market, those usually I have seen that the patients don't tolerate well those ORS. So I think I would advise her to make own homemade liquids, which will keep her hydrated and she can tolerate also.
Yes, and to improve this or to add on to this, whether you would like to add some supplementation, which in fact will, you know, improve her oral intake as well, and improve on her nausea part.
Yeah, of course.
All the hormones in pregnancies are supposed to, intolerance is going to increase that.
Actually, I would like to say here that we can prenatally start her with pyridoxine, ma'am. So that will be, even if given prenatally and then continued, it will help a lot in her controlling this nausea element.
Correct. Anything else during this pregnancy? Now she's facing hyperemesis. Whether you would like to add something?
Doxylamine succinate.
That is one. What do you feel? What do you feel? I would like to invite Dr. Manju Verma. Madam, what do you feel? What is the role of this complementary treatment options?
Will it predict and prevent
Is Madam there?
I would like to say here that since she is a mild case of MSS, and therefore she should be first is the non-pharmacological or lifestyle changes and the changes in the diet that should be done the first line of management. She should have small meals more frequently, should have liquid either before or after meals, and she can can have somebody else to cook her food, because so many times smell also makes them nauseated. And the other thing is that she should take a little more rest. And and some people have even said that they can have snips of ginger and lemon, so that they can have relief of the symptoms. And the other thing is that if they keep something into the mouth, because this results in the peristalsis, and the anti-peristalsis will not occur if the peristalsis continues. So they are supposed to, they should be asked to keep something like a lemon drop or something into the mouth, so that the peristalsis continues.
Correct. Thank you so much, madam, for your contribution. Very valuable. So with this, we would like to go ahead with the second case now. Dr. Rashmi, we would like to start from, we would like you to take up this.
Yes, ma'am.
We have this second gravida, para 1, who is having 1.5 months amenorrhea, and she is brought by the relatives with continuous vomitings almost 8 to 10 times per day, giddiness, weakness, dehydration, and weight loss as well. Compared to her last month, she has lost significantly. So how do you manage her?
Yes, ma'am. If the patient knows her preconception weight, and if there is loss of weight by more than 5%, the management of nausea, vomiting in pregnancy would definitely change. First, I will help her in correcting her electrolyte imbalance with IV fluids and start her and
I would interrupt you here. See, whatever she's taking in, she's vomiting out. So whatever medication or whatever supplementation she's going to have, she's going to vomit out. So first and foremost, what you would like to give her?
IV fluids to correct her dehydration. First thing. Then another
antiemetics, injectable?
No, first I will start with pyridoxine, doxylamine, and if not corrected, then I will try ondansetron as an antiemetic, ma'am. Third thing is getting her USG done to know that if it is a singleton pregnancy or multiple pregnancy.
Yes, causes, etiology of hyperemesis.
Is there any chance of vesicular mole? Is it the cause for her hyperemesis gravidum? That will be confirmed, and then accordingly the treatment of that patient can be done.
Correct. Correct.
So I take up that yes, 75%.
So suppose now you have given her some form of injectable antiemetic, so that she can tolerate. Maybe she's having hyperacidity, so you're trying to control it. You're giving her supplementation with IV fluids, and naturally, because she has suffered so much that she's even losing weight, so some form of vitamin supplementation.
Yes,
so with this, but the patient is very anxious, not sleeping well also. That is not going to solve her problem. So adding this pyridoxine or pyridoxine and doxylamine or any of this combination, but on priority pyridoxine or pyridoxine and doxylamine, right? So that is, so
and madam, tender loving care and
development of positivity, telling her that nausea is quite normal, vomiting, maybe few vomitings are normal, not to worry, and then supplementing, bringing her back to her original status, and then maintaining and advising about her diet intake and adequate rest, as madam has pointed out very rightly.
Madam, tender loving care and maybe change of environment, and these are two very important things. Even a change of her location, like sending her for her mother's place for a
from in-laws to the mother's place. Yes, I understand.
So that really helps.
Yes. So that may also add comfort to her psychological state. So thank you, Rashmi. You have discussed the case very well. So we go to Dr. Deepa now. Deepa, we are coming up with few rapid fire questions after this, but I would just like to ask you, hello, Dr. Deepa, are you there?
Yes.
Yes, I can't see the whole thing in one panel. Yeah. So we have this primary. Yeah. Dr. Deepa, we have this primary gravida, 20 years old with 6 months amenorrhea. And she's having excessive vomiting, weakness, fatigue, and pain in abdomen. On further inquiry, she gives history of fever, pain in abdomen, especially periumbilical region. When you examine, you find that she is mildly febrile, she has tachycardia and mild dehydration. She's got tenderness in umbilical region and right iliac fossa, though there is no distension, guarding, and rigidity. How do you, what differential diagnosis you have, and how do you manage this case?
It's actually a very good question, ma'am. Am I audible?
Yes, Deepa.
Okay. What we shouldn't forget is somebody with hyperemesis we should not miss other medical conditions or surgical conditions that can coexist. Sudden worsening of vomiting and the appearance of abdominal pain, which is sudden. So that will give a clue that something else is happening to her. It's not the routine vomiting of pregnancy. And this patient has a periumbilical pain. She is febrile. So there is an infective and inflammatory process going on, and very likely she has a periumbilical pain and right iliac fossa tenderness. So it could be acute severe appendicitis. So we should not be missing that. She can undergo some basic blood tests like full blood count, and then we can do an ultrasound to see cells or something. And it's difficult to do CT in this patient, so MRI would be another option. To find out if she is developing acute severe appendicitis that requires surgery.
Yeah, I think, you have pointed out it very nicely, Dr. Deepa, but I don't think we need CT and MRI for this. I think a basic, first and foremost, the message here is, being an obstetrician gynecologist, we should not forget that yes, there can be some medical or surgical emergencies as well. That's the first thing. And whenever you have a persistent or prolonged vomiting of this 6 months duration, that too associated with other symptoms and signs, definitely you have to give a thought that yes, some other medical or surgical emergency can be there. So it can be a coexisting appendicitis, or maybe diverticulitis, maybe some perforation or whatever, some surgical cause, or may it be just hyperacidity. But here the patient is febrile. But yes, mild fever or elevated temperature and dehydration can be just the manifestation or a result of hyperemesis, because she has landed up into dehydration. Madam would definitely agree with me. So, you have to keep all the possibilities, but then you have to evaluate. So go for ultrasonography, complete abdomen and pelvis. I think that should solve our problem and come to the diagnosis. So as Dr. Sampath Kumari has already said that yes, up to 16 weeks, you may have this nausea, vomiting of pregnancy, but anything beyond that, you should always think of something else. Even in obstetrics, we have prolonged or delayed or extension of this vomiting, especially in cases of pregnancy induced hypertension, where you are suspecting the patient can land up into severe complications like eclampsia, HELP and all this. So a persistent or freshly appearing vomiting during second trimester is also a warning sign. And as we have already discussed this, that metabolic and hormonal, these are the two main factors for nausea, vomiting, but gastrointestinal tract, immune system dysregulation, and H. pylori infection. Of course, what all of us have agreed that the psychological predisposition. I'm sure somebody said she's very sensitive. These are the sensitive women who are, likely to develop hyperemesis rather than nausea, vomiting of pregnancy. And that's the very reason we have to give a thought to all this etiology. I don't think this is just a theoretical discussion, so I will skip this slide. But whenever you have this patient of, fresh appearing hyperemesis or a delayed or extended vomiting of pregnancy, should definitely think of some other infective pathology as well, like urinary tract infections and some GI infections. So once you go for the basic treatment, as all of you have contributed, that yes, basically giving positivity, telling her that yes, this is quite normal, not to worry, but if it is causing discomfort, or it is causing some disturbance in the routine activities, definitely we would go ahead and investigate this woman for other etiology of this hyperemesis. So what do you feel is the therapeutic recommendation for management of nausea, vomiting of pregnancy? What are the guidelines? So here I would like to invite Dr. Sampath Kumari for this.
These guidelines is always.
Yes.
Yes, you have told we have to take the vitamin B6. B6 is the main anti-emetic agent, I will tell. With the B6, you can go with the doxylamine. And whatever, if most of the time the iron itself will produce the vomiting. So for certain time, we have to stop the, if iron is started already means, normally we start the iron once the vomiting is completed. If it is already started, we have to ask her to discontinue it. And whatever needed, whether if she is not able to take the food, whether she is not able to take the iron means, parenteral administration can be given. Of all this counseling. So we have to take the patient have a feeling, whatever I eat, I will go for a vomiting. So what normally I used to counsel, take some food, vomit, wash your face, again you take the food. So the counseling, that this is a normal physiology, and if it is not the pathology, the counseling the patient, and for a supplementary, you can give this doxylamine, B6, whatever antiemetic, even the metoclopramide, whatever is needed, we can give. If it is very severe, we can go with the IV fluids. So this is the guidelines. Also, treatment of nausea and vomiting with vitamin B6 plus doxylamine is safe and effective and should be considered first-line pharmacotherapy.
Correct. Very rightly pointed out, madam. Preconceptional vitamins, mainly the folic acid and vitamin B6. During pregnancy, vitamin B6, doxylamine and pyridoxine. And yes, of course, you have to discontinue the iron containing preparation. Whatever is going on, you have to stop on this. And of course, maybe you just give dietary supplementation of the iron, which will not cause nausea and vomiting. So very rightly pointed out, madam, a very good take-home message. And of course, whatever we have talked about, the complementary treatments like ginger or something to chew, which will, in fact, stop her excessive salivation as well. Keep her throat also moist, and acupressure and acupuncture, which I don't have any experience about it, but definitely these are quoted in all the guidelines that yes, they do help in the control of hyperemesis or nausea, vomiting of pregnancy. What do you feel? I would just like to have the opinion of the panel. As far as the other antiemetics, H1 receptor antagonist, what is your opinion, Dr. Indrani?
Yes, ma'am.
H1 receptor antagonist, any role in this hyperemesis? And Dr. Rashmi, I would like to ask you about metoclopramide.
Yes, if it is not like subsiding with the normal doxylamine, and then we have to escalate, and if required, we have to give metoclopramide also, and she might need, but usually if for my practice, I usually, if the patient has to be managed injectables, then prefer ondansetron for her actually.
Sampath madam, what is your opinion?
You can give ondansetron. There is no complications and there is no proved to be the contraindications. Though it can be, sometimes it is very helpful. I also use that ondansetron groups of drugs.
Exactly. Even patients who cannot tolerate any pharmacological agents for that matter. You can have the mouth dissolving tablets. So definitely ondansetron is going to be rather, it is very helpful if at all the patient has hyperemesis and cannot take anything orally. So you can definitely control the nausea vomiting with this. So I just have few rapid fire questions for you panelists, which we want to give the message to the audience. So as we have said, as far as the drugs, which drug you feel the most preferred one, whether it is doxylamine alone or doxylamine pyridoxine combination, or it is ondansetron metoclopramide. You just let me know in the order of priority. We would start from Dr. Charu. Dr. Charu.
Yeah, right. I prefer pyridoxine and doxylamine as the first line. If that does not help, then I think of metoclopramide and or ondansetron. First and foremost, of course, dietary modification is what I would definitely recommend 100%.
Yes, no, we are talking about pharmacological agents. You're right. But before metoclopramide, we grade, ondansetron. We prefer ondansetron over metoclopramide. As far as
actually,
there
are studies which say that metoclopramide is probably a better drug for NVP because it has dual action. It increases gastric motility, and that's why they claim that that should that is what studies say. But I think today we use more of ondansetron undoubtedly.
Yes, Madam Manju Verma, I would like to have your opinion on this.
Here I would like to say that you can grade as the first line drugs and second line drugs. Yes. The first line drugs are basically the doxylamine and pyridoxines. And chlorpromazine and promethazine, they are supposed to be, according to WHO, to be the first line drugs. The second line drugs can be metoclopramide, domperidone, and ondansetron. So this is how you can grade that we should try the first line first, and if there's no improvement, then we can go on to the second line treatment. Correct. And even they have described the third line also regarding as one of the things to be used as corticosteroids. Though I have in my life, in my practice, I've never used this for nausea and vomiting. But this, the corticosteroid has also been introduced as the third line drug for the management of nausea and vomiting.
Right.
Okay.
Phenergan and steroids. That's right.
Yeah. Preferably, yes. What Madam has, you have a long list of drugs, but according to your priority, we have to select. If it is not responding to the higher order drug, then only we have to go ahead. So naturally, the preferred ones are the safer ones. Correct. So now, Dr. Indrani, I would like to have your opinion. Is it a necessity to supplement L-methylfolate with these drugs? I'm asking you very clear opinion. L-methylfolate along with the anti-emetic drugs.
Yes, I think I will continue with her L-methylfolate.
Yes, that is one.
Yes. Iron, I would like to stop the iron, that will, but otherwise folic acid, I will definitely continue.
Exactly. If the patient is on ferrous sulfate folic acid, if at all she is having vomiting, you omit, delete iron, the ferrous sulfate, but you continue with the folic acid. The reason being, what we are, considering even in the periconceptional counseling or preconception counseling, that the woman has to take periconceptional folic acid and that is L-methylfolate. Nowadays, we are preferring it because we know 50% of the population is deficient in the, that enzyme which is required for the conversion. So MTHFR deficiency. So L-methylfolate, which is an active form of this folic acid, definitely we need to supplement. It's not for that anti-emetic, it is for the pregnancy which we are supposed to continue periconceptionally, right? Because some people, they have these controversies. So these are the questions which have been asked. Do you follow the modified pregnancy unique quantification of MS's nausea? PUQE, Pregnancy Unique
PUQE.
Quantification of
Questionnaire.
emesis and nausea. Scoring. Do you follow?
Not in practice.
Not in practice.
Yes.
Theoretically,
naturally.
yes, but not in practice.
But
It is only
punch-
for making academics, like, to teach the students, but
Correct.
actually in day-to-day practice, not following.
Exactly. So, Dr. Deepa, this is a question for you. Do you recommend or prefer doxylamine pyridoxine plus L-methyl folate combination in NVP as once a day or twice a day therapy?
Doxylamine and B6 need to be given twice a day. So I think L-methyl folate once a day will do. So the combination, if the patient is comfortable taking, if she has too much of vomiting, then a single tablet would benefit. Otherwise, I don't see any reason why we should stick to a
So
single.
once a day also is okay, because L-methyl folate, what dosage required is there present in the single tablet. So if it is if it is only for the vomiting, we want to give her 2 tablets, then it is okay. But if she is comfortable with the single tablet of antiemetics, doxylamine, and along with L-methyl folate, once a day dosage should suffice. Okay, so Dr. Rashmi, over to you, the last question now. Do you recommend doxylamine in combination for NVP? As whether it is, SOS whenever required, or you prefer to prescribe as a routine? Dr. Rashmi? I don't think, do we have her? I can't see the panel complete. So I think, yeah, Dr. Indrani, you can comment on this.
Yeah, you were asking whether it is a combination.
Yeah.
Like
I would use it as a combination.
Yeah, symptoms, I think if she's having the symptoms, I would refer as a routine. I would not put her on SOS. I would put her in routine and let the symptoms subside, and then later on she can go for SOS. Initially to calm her and all, to get away with the fears and all of that. So I think I would put her as a routine dose.
Correct. So just to summarize from my side, whenever we have this pregnant woman who is developing nausea, vomiting of pregnancy, and she asks for help or she needs help, we have to help her with first basically to understand that pregnancy nausea, vomiting is a common and a normal symptoms, unless it is disturbing her physically and psychologically. So first and foremost, she has to relax physically as well as psychologically. So take adequate rest and be relaxed mentally. Develop positivity. Think of the positive things of pregnancy. Modify her diet. Lots of fluids, preferably no aerated or no energy caffeinated drinks or soda. No, foods which are, very mouth watering, what we call. These are the things which they are leading to emesis of pregnancy, mainly stimulation of all this salivation, etc. So what you have to advise is go for small frequent meals, especially bland food, not to have very oily, spicy, hot and sour foods. If all these things help her, we have to tell her that it's going to be maybe only up to 3 months of pregnancy. If at all, later on it will be very little, quite comfortable for her. But the choice of, if at all, she needs some pharmacological aid and drugs, definitely pyridoxine and doxylamine. Both Canadian and American guidelines, they recommend early recognition and management of nausea by all this combination. It should be a standard of care as first-line treatment, since there is very strong evidence to support the safety and efficacy. So with this brief discussion, I will now have the expert comments from both Madam Sampath Kumari and Madam Manju Verma. Over to you, Madam.
Yes, Dr. Sneha, well said. Normally, we should ask the patient to divert her mind to be engaged with some extracurricular activities to learn something new. So psychological counseling is very, very important. And if needed, you can go for the medical management. This is my message. That's all.
Thank you so much, madam.
Thank you.
Madam, your message, please.
I would here like to say that with the younger generation and the CPA coming out, I think the PUQE should be followed by the younger generation, because you never know who is going to sue us in the court. And it is very simple, 24 total count, and it is 3 to 7, 12 to, 12. No, it is less than 1 to 6, 7 to 12, and more than 12. If you find out it is more than 12, I think it is better straight away going for the IV line and IV treatment. For the milder, you start with the lifestyle management and pyridoxine. If you are not able to manage, add the doxylamine. If you are still not able to manage, that means she goes into the second category. That means she is into the moderate type, right? And with the moderate, you have to add the second line treatment, that is the metoclopramide and the ondansetron plus the saline infusion, because the most confusion that goes on is that we give glucose. So one should not straight away give glucose, because there is a thiamine deficiency which is very, very common and can result in number of complications. And therefore give the thiamine first and then give glucose. And otherwise one can give normal saline. So I think this was a wonderful panel that I have with you, Sneha and Sampath. And I say I will simply request the younger generation to please be calculative. Yes. And we should be, we should, try to, something which can be, we can prove it, documented that it in the court. So this is the thing, and I've done it, and it is something which is correct. So that is what I would like to say.
Thank you so much, madam. Purposefully, I have skipped this slide. Yes, the PUQE scoring, if it is less than 6, then mild nausea, vomiting, or pregnancy, and where dietary modification and lifestyle changes should suffice. There may not be any need of pharmacological agent, as you have rightly pointed out. A score of 7 to 12, complementary treatment in the form of need for vitamin supplementation, ginger, acupuncture, acupressure, and nerve stimulation at P6. And of course, the pharmacological agent to be added, pyridoxine, doxylamine or pyridoxine in combination, and the second line, as we have discussed, diphenhydramine and metoclopramide, ondansetron. But if the symptoms persist or if the score is above 13, then initial treatment, as we have said already, additional, we have to add some antiemetic, need for hospitalization, rehydration with the IV fluids, especially sodium chloride, correct the electrolyte deficiencies, if at all. As Manju madam has pointed out, thiamine infusion, need for IV vitamin supplementation, and then dextrose, of course, to correct the sugar levels as well. Aggressive treatment may be needed if at all the score is high and the vomiting persists in the form of enteral tube feeding, parenteral nutrition, and corticosteroids for refractive hypergravidarum. So with this, I would like to end this discussion here. Thank you so much, everyone.
Fantastic, Dr. Sneha. Thank you
so much, ma'am, for the
opportunity.
Thank you.
It was
so
a wonderful
much.
session.
Thank you so much, Manju madam, Sampath ma'am, and thank you all my panelists, Dr. Indrani, Dr. Charulata Bape, Dr. Rashmi Kahar, Dr. Meeta Gupta, Dr. Deepa Mukundam, and thank you, Vasist and Vasu.
Thank you. Thank you so much. Thank you so much, ma'am.
And over to you, Vasist.
Thank you so much, all the respected faculties, for sparing your valuable time. So we would like to have such kind of virtual discussions in future as well, ma'am. We are looking forward.
Do we have any questions, Vasu?
No, ma'am.
Yeah.
No, ma'am. We don't have.
So whatever 3-4 questions we had, we have already discussed. And thank you so much, everyone, for being with us. and having this wonderful contribution from your side.
Thank
Thank you so much. ma'am.
Thank you, Sneha. Thank you.
Thank you.
Bye-bye.
Everything in time, in time.
Yes, thank you
you,
so
ma'am.
much.
See you.
ma'am.
time.
Thank you.
Thank you. Goodbye. See you all.
Bye.